is going to be Dili or drug-induced liver injury. So this is a very now this incidence is on the rise, and it's a very common condition which we are seeing now because of a which is associated with a lot of prescription medications, over-the-counter medications, and a lot of herbal and dietary supplements. Uh, Most of the patients are present. They present with a mild to very severe liver disease symptoms, and sometimes they may even progress to requiring a liver transplant, without which it is a potentially fatal condition. The clinical picture is very often, it has many confounding factors, and it may mimic an autoimmune liver disease or a flare of a pre-existing silent liver disease. So we are very reliant on an accurate history. So today we will delve into the various aspects of drug-induced liver injury. We will be discussing it as 4 case presentations, and the discussants are Dr. Bhargav, who is a senior registrar in the Department of Hepatology in Srmc Chennai, and Dr. Sachin, who is also a senior registrar in the Department of Hepatology in MMC Chennai. The faculties involved in the discussing the various cases are Professor L. Venkatakrishnan, Professor Verghese Thomas, Professor Ganesh, and Dr. Hema Mala. We also have a special guest lecture at the end on Dili by Dr. Harshad Devar Bavi, who is a professor and head of the Department of Gastroenterology in St. John's Medical College and Hospital, Bengaluru. We will now start the case presentations, please.
Thank you, Swati, for that kind introduction. While Dr. Verghese Thomas is joining, I think we can just start off with the first case presentation. So I'll be presenting the case, and the first case will be discussed by Dr. Bhargav. And our discussant will be, take up the discussion, we have Dr. Verghese Thomas, who's a professor of gastroenterology at Malabar Medical College, Calicut. And in case there's a delay in joining, we request other faculty members to chip in and take up the questions. So we have 4 short cases. The first case is on amiodarone and hepatotoxicity. So this is a 75-year-old lady who had come to us in September 2020 with a history of abnormal liver biochemistry. She had several comorbid states such as diabetes, hypertension, coronary artery disease, dyslipidemia, hyperthyroidism, and also had cardiac issues like atrial flutter, ventricular premature beats. She was on follow-up for bilateral varicose veins with non-pitting edema on both lower limbs. In the treatment details, she was on Nicardia plus simvastatin, olmesartan, metoprolol, and also was on amiodarone for almost 2 years. On examination, she was short stature, vitals were normal. There was doubtful icterus with gross non-pitting edema of both the lower extremities. Cardiovascular respiratory system, except for the abnormal rhythm, which was actually normal. Everything else was normal. And abdomen examination revealed a liver that was 2.5 centimeter below the costal margin. While evaluating her lab parameters, the WBC count was slightly elevated. INR was 1.4. The sugars were normal. RFT and serum electrolytes were also normal. When we had the serial liver biochemistry in this patient, that is until 22nd of January 2022, we found that she had abnormal serum bilirubin level, which was predominantly conjugated, and AST, ALT, which was marginally elevated. This was around this time that we had stopped the medication after the October 2020. And alkaline phosphatase and gamma GT continued to show elevation, and albumin was fairly normal throughout the period that she was on follow-up with us. The other parameters that were looked into, thyroid was normal, CRP was mildly elevated, serum IgG was also just marginally elevated. The autoimmune markers were all negative, and tumor marker profile was also negative, which included alpha-fetoprotein C and CA19-9. The CECT abdomen was done, MRCP was also done. So upper GI endoscopy showed a large periampullary diverticulum. The fibrosis score was F4 with a steatosis of 219, and Doppler study was essentially normal, and echo showed a mild TR and MR. So this was the endoscopic view where we had a large periampullary diverticulum which had actually food residue within it. On the 3rd of December 2020, she had a worsening of symptoms. There was cough and she had gross worsening of the edema of the legs, ascites and pleural effusion. HRCT chest was also done. She also had an acidic and pleural fluid analysis. It was a high SAG, low protein, and there was no evidence of SBP, and ADA was normal. There were some atypical clusters seen in pleural aspirate, but the repeat cytology was negative for malignancy. So these are some of the images that we have of this patient. There was no evidence of COVID on the plain chest X-ray, but there was a collapse of the superior segment of lingular and lateral basal segment of left lower lobe, as was seen on the CT, and subsegmental atelectasis in the posterobasal segment of the right lower lobe with the pleural effusion on the left side. The CT and MRCP and MRI showed that the liver and spleen were essentially normal. There was hepatomegaly. Diurnal diverticulum was seen. There was mild dilatation of the CBD with moderate ascites, and there was a small hypodense nodule in left lobe of thyroid, which actually she underwent FNAC, and that was actually normal. So with this brief introduction, I would like Dr. Varghese Thomas, if he has joined, or Dr. LVK, or any of the other faculty members, to just discuss briefly, summarize this case, and then take up the questions on this particular case. If Dr. Varghese is not joined, Dr. LBK or Dr. Ganesh or Dr. Hema can take it.
I am here, but
Yeah.
I will take 5 minutes to reach home.
Okay.
So the resident may start off the discussion. There are two issues which I want to clarify. When the patient came in 2020, she was already on amiodarone and she had mild LFT abnormalities. And whether she continued amiodarone or stopped amiodarone, that is one thing. I think she continued amiodarone. And currently, she has presented with the pleural effusion and ascites. This is what I understand.
Exactly,
am I right?
Yeah, exactly, yeah, that is true. And she had this abnormal deranged liver function test.
Okay, so I would like to know whether she was advised to stop amiodarone in 2020 or whether there was a reduction in the dosage advice. That is what I want to clarify. I want to get clarification.
Bhargav?
And another thing I want to know, arrhythmias and related problem, at any time recently whether she was given any IV amiodarone. Because amiodarone can be given orally as well as by parenteral route, and both produce a different
modes of action. Yeah, Bhargav?
Sir, actually patient was not on IV amiodarone. She was only consulting cardiologist on OPD basis, and they have started
the concerned resident.
Yeah, he's speaking. He's answering. Bhargav is answering.
Can you
Okay,
hear me?
Bhargav, what was the dose of amiodarone which she was taking for the last 1 or 2 years? Was it reduced when they noticed that there is a liver function abnormalities when she was seen in 2020? Was IV amiodarone given at any time?
The patient was not given on IV amiodarone. She was only on oral medication at a dose of 200 mg twice a day.
Okay, fine.
And she had no monitoring of liver function test. She came to us because of a deranged liver function test and a possible jaundice. So Bhargav, we can take up the issue in this case.
Any other previous history of liver disease?
Has multiple comorbidities that included diabetes, hypertension, dyslipidemia. She's also a coronary artery disease with history of palpitation. Then they noted arrhythmias, and they have started on amiodarone along with other antihypertensive medications.
Bhargav, I have a question for you.
Yes, sir.
The fibrosis score is F4.
Yes, sir.
Does amiodarone toxicity cause liver fibrosis?
So you just take up the discussion. Yeah, Bhargav, just continue.
Yes. But are we sure that this is amiodarone toxicity, or she also has so many other comorbids which could have contributed to the development of chronic liver disease and decompensation like you have already presented?
Yes,
So,
sir.
but
Sir, actually, in this case, that is one of the issues where she has multiple drugs which she has been taking for many years, and underlying multiple comorbidities are there. So whether the F4 fibrosis is whether due to drug-induced liver injury or underlying some other cause like NASH, that has to be ruled out. So in this case, she has one of the main issues. She's taking multiple drugs that include amiodarone, nicardipine, statins, olmesartan, and metoprolol. So when we see among the different drugs, only the amiodarone, that is iodinated vincristine and derivative, it's an anti-arrhythmic agent, which causes 15 to 50% liver toxicity on only on long-term therapy. And only when IV amiodarone was given at high doses, there were case reports that have shown hepatotoxicity. Otherwise, it's a total of cumulative accumulation that's causing drug toxicity in amiodarone. Other drugs which can cause liver toxicity, like statin, which is around 1.9 to 5.5%, which causes idiosyncratic liver injury. Predominantly, statins which cause liver injury are atorvastatin and simvastatin. Drugs like nicardipine, olmesartan, and metoprolol, very less chance of causing liver toxicity. So the causal relationship between these drugs and hepatotoxicity in this case. So mainly when we see the causality assessment method and different scales, the predominant method we follow is the Russell-Lukloff causality method, which is known as Recamp. It contains 7 domains that includes time to onset, course, risk factors in the patient, concomitantly used other drugs, any other non-drug causes to be excluded, and previous any similar drug hepatotoxicity noted in the patient. And when respond to drug re-administration, there should be similar response or there should be a flared up response. So overall score can be divided based upon whether less than 1, it can be excluded, Dili can be excluded, and more than 8, it is highly probable. So other methods included Japanese criteria, CDS, etc.
so we are just taking up this question on what are the pointers in this particular patient. Yeah, so you can just discuss this.
So some of the points which were favoring amiodarone-induced drug toxicity in this patient is 2 years duration of intake with no liver function test monitoring. Other drugs, as we have told previously, less likely or less toxic to cause the hepatotoxicity. Viral etiology and autoimmune has been ruled out in this patient, and underlying multiple comorbidities also is one of the independent risk factor for causing drug-induced liver injury.
So this is what they want to ask. Could there be an underlying NASH component in this patient? So can you just address that? Is there a NASH likelihood of a NASH component? And is there any role for liver biopsy for confirmation of the diagnosis?
Yes,
so is there a biopsy, madam?
No, before that, what was the likelihood? Because amiodarone is a well-known drug and its hepatotoxicity is well-known. So what is the type of liver injury produced? Because each drug has a signature pattern. So this patient has now sort of decompensated at the end of 2 years. So obviously we have to think of either acute form of a liver damage, acute and chronic, or a chronic. Okay, whatever it is. So he has decompensated. So we have to find out what is the most likely pathological change in the liver and whether that can be produced by amiodarone. There is such a decompensation.
Likelihood is there are 2 possibilities. Drugs are there, plus of course underlying NASH cannot be ruled out, no? Because all the other factors are ruled out. So I think
amiodarone is also notorious to produce a picture which is very similar to alcoholic liver disease. That's biopsy.
Yeah.
You find almost all features which are like a micro fatty, macro level fat in the cells. Then malary bodies and so many things which looks like exactly like alcoholic liver disease. So there is a component of non-alcoholic fatty liver disease which is a different type which happening in amiodarone. Okay, so whether it is ultimately producing something like cirrhosis is another thing which you have to find out. So she has whether NAFL, background, whether amiodarone induced NAFL, the so-called NAFL, and whether it is a primary liver damage due to amiodarone due to some other type, because it is well known to produce hepatocellular plus cholestatic pattern. Both are possible, and an acute liver failure is known only if IV amiodarone is given. I have never had IV amiodarone, so we cannot consider that entity at all.
Yeah.
Okay.
So, Bart, what should we do in this patient?
Amiodarone
Yeah.
induce chronic Dili as well as cirrhosis. If you look at the,
Cumulative.
we don't have an entity called as chronic Dili, but amiodarone can
something
induce
like chronic hepatitis leading to cirrhosis. Is that
yes. Yes.
Yeah. Chronic hepatitis evolving into cirrhosis. Yes.
More of a cumulative effect, I think. No? Over a period of time, it accumulates and causes a problem. I understand, right? So, in this particular patient, for management purpose, Bhargav, do you think that a liver biopsy is indicated? That is our question. Or what we did was we stopped the medication first. They got a referral with the cardiologist and they requested them to stop the amiodarone and switch over. That's the first thing that we thought we should do. That's what we did. But having said that, would you still consider the need for a liver biopsy in this patient?
Ma'am, if the underlying is settling after stopping the drugs, then I think we can wait and watch, not going for liver biopsy. In spite of stopping all the drugs, patient is having prolonged hepatocellular cholestatic pattern, then liver biopsy can be indicated. And also, if an injury is detected, even for the prognosis, liver biopsy can be as a baseline.
And I think, as Dr. BT mentioned, there can be mimickers of primary hepatic and biliary disease. No, so I think that was a point well taken.
I would consider a liver biopsy for the following things. See, she is an amiodarone. She has got multiple comorbidities. Once amiodarone-induced liver goes into cirrhosis and portal hypertension, and they decompensate, they don't recover. So I think liver biopsy will give us a. The problem here is you can argue out that the patient has got a high F4 by your fibroscan. But the point here is there are also the SGOT, SGPT was cancer point of time. We don't know what's it. So is it this patient is being driven to fibrosis, or it could only be cholestatic? This is something which a liver biopsy will tell us. Because amiodarone can come like a chronic Dili, like a cholestasis, or it can push itself like an hyperfurantoin into a cirrhotic stage. So that will give us a clue and predict what will happen to this patient once you look at the liver biopsy.
Yeah, she'd already decompensated, so and she was also in F4 fibrosis with and additional involvement of the lung as well, lung collapse and pleural effusion on the left side. And interestingly, she also had this periampullary diverticular, and as Dr. BT, as ET and Dr. LBK mentioned, she had this prolonged polystasis. Alphas and gamma GT continued to be high. So most of these periampullary diverticular are usually asymptomatic. But occasionally they can present with episodes of jaundice and cholecystitis. And as I think liver biopsy at that stage may be essential, we also thought whether we should place a stent and see whether cholestasis comes down. So that was also considered in this patient. So you can summarize this one particular
just one observation, madam. Generally, these patients, if you do a CT scan, the liver is usually very bright without the contrast, because they're all having iodine accumulation in the liver.
Sure.
So I think that could be a point, probably, to say that she has got hepatotoxicity. That could be a point to say that it is primarily, probably secondary to amiodarone.
Point well taken. I think that we did not observe that on the CT, but probably we didn't consider seeing that aspect as well. So
okay, I just want to add one more point. In fact, even without toxicity, also the liver may accumulate a lot of amiodarone. So, on a non-contrast CT, liver will appear as though there is a contrast. Is that not the finding, Professor Ganesh?
Yes.
Non-contrast CT, the liver will appear bright.
Non-contrast CT, liver will be very bright.
Right. That's very nice. That's a great point. So actually, our patient has a combination of hepatocellular and cholestasis, moderately severe, latencies of 2 years. This is how one should report for the postgraduates on the reporting of a Dili, and also mention other medications that the patient is on. And in this patient, as far as recovery is concerned, she did and she continues to have ascites and marginal derangement or liver biochemistry even this month when she came for a follow-up. So I just briefly summarize basics that amiodarone is a lipophilic structure with a half-life of 25 to 100 days, essentially an antiarrhythmic drug. Long-term, you can get thyroid dysfunction, which this patient had, hypothyroid, you can get pulmonary and hepatic toxicity. Mechanism is both direct toxicity and metabolic idiosyncratic relation. And since amiodarone affects several systems in a given patient, you have to assess and see before introducing amiodarone, the cardiac status, the dermatological status, endocrine, ophthalmic, pulmonary, and as far as the liver is concerned, the baseline AST and ALT. So the clinical presentation can be just mild elevation of transaminases, majority are asymptomatic, symptomatic are less than 3%, and potential complications are cirrhosis and heart failure. Jaundice is an unusual adverse effect, and interestingly, because of the cumulative effect, one can continue to see a rise in bilirubin even after discontinuation of the drug, and the long half-life is 25 to 100 days. So just to reiterate the fact that when one should introduce amiodarone, I think it should have a baseline hepatic function and repeat the tests based on the events. Like this particular patient has a NASH component in addition to amiodarone. So I think I would definitely follow up every 3 monthly and see what it is. The question of liver biopsy, she is 75-year-old, she has a cardiac problem, and she already has F4 fibrosis. So I'm not certain how much extra change in management would occur with the liver biopsy. We can just take up a point for discussion on this. And if one has to continue amiodarone, I think it has to be maintained at the lowest possible dose. So I think Dr. LVK and Dr. VT, you can just summarize and say just take-home messages for amiodarone. When a person needs amiodarone, or if it has to be stopped, of course, then it's onus on the cardiologist to start the different.
Yeah, as you rightly pointed out, a thorough clinical evaluation initially, including AST, ALT, and while on the treatment, AST, ALT is to be repeated. And if it is fine, okay, continue it. If the AST, ALT is elevated even up to 5 times without an elevated bilirubin, this may pass off after some time because it could be due to drug adaptation. Okay, but if the bilirubin is also elevated and if the AST, ALT is elevated more than 5 times, this is suggestive of Dili, and then one has to reduce or stop it. The problem with the reduction with amiodarone is that unlike other drugs, amiodarone half-life is almost 6 months. So don't expect any immediate drastic results when you stop amiodarone, because amiodarone can linger in the body for a long period of time, and then the effects may continue and linger for a longer period of time. But over to Dr. Venkat.
LVK, about the liver biopsy in this particular case.
Now, the only thing why I just wanted a biopsy on this, of course, this patient has come with decompensation, but she has also got a lot of other comorbidities. So there have been underlying NASH on this. So a biopsy will give us which is the prominent one. Is it a drug-induced or a NASH? Because amiodarone has got a certain pathologicals. It can produce chronic Dili, it can produce fibrosed cirrhosis, and at the same time, it can produce secondary sclerosing cholangitis. So is it the NASH which is driving the whole thing, or amiodarone? But to tell you, once we get a biopsy and it shows fibrous cirrhosis or a secondary PSC, then it becomes irreversible. That is the point which I think I would be interested in a biopsy.
Yeah, and I think if the person was a young patient, say 40, 45, I think then that's all the more important for liver transplant.
The liver, we can prognosticate the liver.
Prognosticate the liver. We just move on to the second case here. Can we move on to the second case? Okay, the second case, Dr. Hema, you're around? Yeah, Dr. Sachin will be taking up this case, okay? A 56-year-old lady gives history of jaundice for 2 months. This is the time she came to us, I think, in the month of December 10th or so. And the jaundice was progressive, non-cholestatic, with no abdominal pain or fever. In addition, she also had abdominal distension, edema, and polyuria, and there was breathlessness and exertion, with no chest pain, palpitation, or orthopnea, no GI bleed, no history of CAM, past blood transfusion, tattooing, or abdominal surgery. She again was a diabetic for 10 years on OHA. And interestingly, she was on treatment of psoriasis since 2019. The physician who was looking after her prescribed her for 1 month tablet Methotrexate on a daily basis. She lost contact with the physician due to COVID times, and so she decided, and she continued to take in the same dosage of 2.5 milligram daily for the next 2 years. And this was the background history that we had after going through the prescriptions that she had. Until then, we were at a loss as to why did she develop a sudden presentation of almost like an ACLF-like presentation. So on examination, she was conscious-oriented afebrile. She was ectric with bilateral edema leg. Ascites was present. Other systems were normal. As far as investigations were concerned, she did have conjugated hyperbilirubinemia with AST slightly more than ALT. There was an AG reversal, and IgG again was elevated, and direct Coombs test was positive. The hemoglobin was 9.4, and the total count was 12,100, and INR was elevated 2.04, and creatinine also was 1.8. So she did have AKI-like presentation with INR that was elevated. And all the serological markers for autoimmune hepatitis were negative, the basic ones. Acid fluid analysis showed high SAG, low protein. Endoscopy showed small esophageal varices. Ultrasound showed a liver that was having a nodular surface, a splenomegaly with moderate ascites, and urine culture was positive for Enterococcus species. So this was the CT which showed, actually the liver showed surface irregularity. And what was more concerning was all these collaterals were there, suggesting that she had decompensated chronic liver disease with minimal ascites. So with this background information, so we came to a conclusion that again we were dealing with a methotrexate and drug-induced liver injury, following the same pattern, taking drug of 2.5 milligram per day for a period of 3 years. Pattern we are not able to define clearly because enzymes were just marginally elevated. Liver cirrhosis and ascites was present. And she came to us just 2 days back, and she is comfortable, she is normal, she feels she's healthy, but on examination she does have minimal ascites, and the underlying diabetes now again suggests whether it is NAFLD that has progressed to cirrhosis, and whether the methotrexate was just a red herring, and she was also on oral hypoglycemic agents. So with this background, and then we had incidentally one other patient that was admitted in CCU, a 32-year-old lady who had a scarred pregnancy, that is ectopic pregnancy. And this particular lady was given by the obstetrician an injection at the local site. And 48 hours later, she presented as classical acute liver failure with bone marrow suppression. And by God's grace, I think we pulled her through with the supportive management, and also GCSF was given for the bone marrow suppression. So we have 2 cases. One with a direct injection of methotrexate into the scar pregnancy, probably it has entered the circulation as IV manifestation, and the other one whether we are dealing actually with the methotrexate which is stimulating, causing, or is it actually a NASH that has progressed to a cirrhosis. So over to you, Dr. Hema.
Yeah, so Sachin is there. So,
yes, ma'am.
So Sachin, so the patient has come with a decompensated liver disease. So she has all the features history-wise is there, and then when you're looking at the history, so the possible etiologies for the decompensated liver disease in her could be NASH because she's been a diabetic for a long time, and then now you have a history of methotrexate. So what is the usual considered to be the toxic dose of methotrexate?
Ma'am, in long term, usually a doses of around more than 10 grams per day is considered toxic, ma'am, if it is being given for more than 2 to 5 years, ma'am.
10 grams, sir? 10 grams per day?
Ma'am, if it is the shorter duration, if we are giving, ma'am, actually it all depends on whether we are giving for short term, so high doses are toxic. If we are giving for long term, ma'am, even 2.5 grams can be toxic, ma'am.
So usually more than 3 grams cumulative. That means over the year. So does she touch that? Even if she has, and you 2.5 milligram daily was given. So usually it is given at weekly doses. Weekly doses, and then so with that, if you calculate, it's close, reaching around 1.5 to 2 grams, the cumulative dose so far.
Yeah.
So it is slightly on the lower range. The 3 grams generally around 30% risk of F2 or F3 fibrosis over a cumulative range. Okay, so how does methotrexate cause liver injury?
Ma'am, it has got 2 mechanisms, ma'am. One is a folate dependent and one is a folate independent mechanism, ma'am. But basically, it is a direct hepatotoxic. It is having a direct hepatotoxic action on the hepatocyte. Plus, ma'am, it increases the number of stellate cells which help in the further progression of fibrosis, ma'am.
So yeah, so two mechanisms are, one is the increased fibrogenesis or inflammatory activity through stellate, and then the folate reduction. So if you had seen the patient in 2019, if that the doctor who had started the patient on methotrexate, okay, the patient is a diabetic, and they send you for clearance, can I start this patient for methotrexate? How would you have approached that patient?
Ma'am, usually this patient being a diabetic with fatty liver, ma'am, it becomes a high-risk patient, ma'am. So the difference in guidelines, ma'am, some guidelines say that all high-risk patients should be under intensive screening, ma'am, with two methods of monitoring. One is LFT and one is imaging in the form of either transient elastography, ma'am. And few guidelines recommend that a baseline biopsy can be done in cases who are high risk. The best method is to avoid the methotrexate altogether in high risk patients. If unavoidable, either we can go with a baseline biopsy or with intensive monitoring with LFT and transient elastography.
Yeah, so suppose if after 1 month of the starting, if they refer to you that SGOT-PT is 70 and 55, what would you do? It was like 30 and 35 to begin with. At second month, it is 75 and 45. What would you do?
Usually transient or mild elevations of AST, ALT will settle down even with continuation of methotrexate, ma'am. But if the enzyme elevation is more than 3 times upper limit of normal, either we should stop the drug or at least reduce the dose, ma'am.
Yeah, so up till 3 times upper limit, we can try to continue. So most of the time, this, so if even though we always talk of methotrexate induced liver injury, methotrexate induced liver injury, but there are two meta-analysis which has been done. It shows the incidence of actually severe liver injury is less. It is because of the other comorbid conditions. So usually it could be NASH, obesity, diabetes, or alcohol. So they are to be blamed more than the methotrexate as such. So they have done, I think, in 2015 as a meta-analysis. It is only 0.1%, less than 1% cirrhosis. So most of the time, it is a pre-existing condition. So I think this lady would have probably have had high-grade fibrosis at the beginning of treatment in 2019. Okay. And methotrexate probably would have contributed in addition to it. So if we had done fibroscan, serial fibroscan, so most of these guidelines about biopsy was before 2010. The evidence is, data is from that. But now some guidelines are talking about periodic transient elastography. So transient elastography, that means if you do it, if it is less than 8, maybe you can repeat the next one after a year. If it's more than 8, probably you'll have to repeat it more frequently. So especially in patients with pre-existing conditions like diabetes. So that is what we are doing. In the previous case also, like when you say that fibroscan was 80, so I think most of the time it is 75 is highest. So when it is 80, that means it is a very high stiffness, but patient did not have usual features of decompensation like low platelets, or there are no varices. So when the liver is so stiff, there will be invariably be portal hypertension. So we should also know the caveats of in fibroscan. So in that patient, probably additional inflammation or congestion from pulmonary fibrosis also we need to think of. So here, if now, of course, she's already decompensated, so no point in doing a fibroscan now, but she's behaving like a decompensated liver disease. Now, once we stop the methotrexate, we don't know whether she's going to go back to the compensated state. Unlikely once the varices, everything has developed.
Yeah, so she appeared to be like we were a little surprised because we had listed her for transplant then, at that stage. Because she was very sick with decompensation, with AKI correction and all that. And we were about to talk, and we started talking about liver transplant. And then we sent her on this albumin twice a week dosage. And she came back to us after 3 such weeks, and she came back yesterday. And ascites is not there now. Edema leg is also not there. But we've told her that at any point of time, she's on that on the gray zone where she can just tilt on either side. So the question was now, at that stage, would she have been a candidate for liver transplant at that stage when she came, Sachin? When she came?
Ma'am, when she presented with ACLF, ma'am?
Yeah, and AKI, and she had that urosepsis. So we corrected that, and then over a period. But at that time, do you think we should have started talking to her about liver transplant at all? Because she was very sick, breathless, She was sick.
Ma'am, if she is stable enough to undergo a liver transplant and given her underlying cirrhosis, ma'am,
Yeah.
which we don't expect will reverse even with stopping of methotrexate, so she is a probable candidate for liver transplant, ma'am.
At that stage.
Majority of the times, this methotrexate induced chronic liver disease is a very smoldering disease. It takes times and goes into liver fibrosis and then goes to cirrhosis. So if she has come with some sort of a decomposition ACLF, did you look into any other things? I have not seen methotrexate
Yes, sir.
induced patients.
So usually
It
methotrexate.
should have been some other cause. Was she septic? Did she have anything else? Did she have any CAM on that? All those things.
There was
Even
no
we
history
had-
of CAM, LVK,
had
but she,
transplanted patients methotrexate, but remember, both one patient is 69, other patient is willing for a transplant. Now we have listed for 71. So, in fact, one of the patients decompensated when he was given a rituximab, developed severe pulmonary infection, then they decompensated. We found out that the patient had a liver. So, probably ACLF would have been due to cause, sepsis, and maybe try to correct the ACF and see stop methotrexate. Really takes a small drink
we're on.
in methotrexate.
Okay, sir.
I'll just send you the message. I'll just send you. Google Meet.
You can
Google Meet.
show the, I think you have some guidelines, no, on the.
I'll just send.
There are just two observations I need to make, Hema.
Yes, yes, sir.
Is it okay?
Yes, sir.
Okay. I think this is one of the drugs which is probably notorious to cause chronic decompensated liver disease. Unlike all the other drugs, the Dilis normally recover. Rarely go in for acute liver failure or death, but to go into chronic decompensation, methotrexate is the most notorious drug. I think we have seen a lot of cases like that. Number two, this drug is commonly used by gastroenterologists to treat IBD also, where they have also given salicylates. Now what happens is the salicylate causes decrease in the methotrexate excretion from the kidney, thereby increasing its toxicity. I think this point one should keep in mind that when you combine salicylates, probably the follow-up should be more strict and more diligent, because you might land up with a liver problem which we have not anticipated. These are 2 points which I'd like to make.
Any other key message you'd like to convey? So in this particular patient, methotrexate was stopped. Underlying chronic liver disease to now be still being considered. And I think in lieu of the ACLF, liver transplant was considered at that stage. And I think what we have told her is more of prevention. We have asked her to reduce the albumin intake. The albumin is now 3.4 to once a week. So I don't know whether that really helped. The current MELD yesterday was MELD 17. So what do you suggest, Dr. Sachin? Current MELD from 19 has dropped to 17.
Ma'am, MELD more than 17 also because of the underlying decompensated liver disease, ma'am. Still, I feel, ma'am, she is a candidate for liver transplant, ma'am.
Only thing, the liver size is quite good, the liver size is normal, and otherwise she looks healthy, I mean, we could not talk about liver transplant yesterday because she just seemed like a normal person, and there was no ascites as well. So I think I would probably proceed with the liver biopsy and confirm whether, do you agree to that, Hema? In this patient, liver biopsy?
The liver biopsy here, she has established cirrhosis. So just to diagnose methotrexate-induced liver injury, I'm not so sure, ma'am. But because he has an established cirrhosis, there's no doubt about cirrhosis here. Whereas in the previous case, there was a doubt, I would say. But here, there is no doubt about cirrhosis. Probably, just to prove methotrexate liver injury, I'm not so sure whether we have to do.
Indicate?
I think she has got cirrhosis, as Hema said.
Yeah.
Decompensate. Could have decompensated because of ACLF and the urosepsis. Now I don't think I'll do a biopsy. But if her parameters have reversed, health has come down, A is restored. And I think I would probably wait for some time before we really think of a transplant in this patient. Always remember in hepatitis C, and sometimes even when you look at the whole European liver registry, sometimes 20% of patients gets delisted from a transplant and they may get postponed. Either it's an autoimmune or a drug induced or something. So as Madam has said that she has come without ascites, if her albumin is picked up, prothrombin time has picked up. Of course, I would expect only the platelet. I think I'll put her back on surveillance. But we'll tell them that if there is any other problem later, we have to see. The first time she has come with a decom with ACL left. And after having stopped Methotrexate, probably we would follow it up before we think of a transplant.
So Sachin, what do you think will be the natural history of this patient? A patient who are decompensated has come back to compensated state. What do you think will be the natural history in this patient?
Ma'am, as we are stopping methotrexate, so that component has been taken care of, ma'am. Once the urosepsis has settled, ma'am, she might come out of the...
No, what will be the natural history? What are the chances in percentage chance of her decompensating in the natural history of a cirrhotic patient? No, decompensated, gone to compensated. Now, what will be the natural history of her going back for a decompensation in the natural history process? And should we keep the family prepared that, okay, at one point, say 1 year, 3 years, 5 years, when can we expect a change? That's what I'm asking. Dr. LVK could just...
What will be a decompensating events? It will be anywhere between 7% year as well as of 8% per year. What follow around these patients? Any cirrhotic patient?
I hope
Yes, there's one more point I like to make, ma'am.
Yeah, please.
Not related to this patient, but in case these patients are on chronic methotrexate intake on a weekly basis, when will you monitor? How will you monitor such patients? Do you do liver biopsy at cumulative doses?
Most of the rheumatologists, they monitor them at monthly or a 3-monthly basis, the CBC as well as the liver function test.
And for the first 6 months, ma'am, we can monitor on a monthly basis.
Varghese sir, anybody?
No, he's answering. Sachin is answering.
Sir, we can monitor the patients on a monthly basis for the initial 6 months, sir. If the liver enzymes stay normal, later we can reduce the frequency of monitoring to 3 monthly.
No, I'm talking about liver biopsy, not the liver enzyme.
Liver biopsy only if there's a high risk group, no? Otherwise, it's not indicated. We don't do it. It's not indicated.
No, suppose he's on a cumulative dose. At what cumulative dose would we plan for a liver biopsy, or it is not indicated at all?
Sir, initially we were following, sir, that a cumulative dose of 2 grams liver biopsy is indicated, sir. But the recent guidelines and research, so some places has shown the association between the cumulative dose and F2 fibrosis on liver biopsy is not very strong, sir. So the cumulative dose is not very much indicative that we'll get a fibrosis on liver biopsy, sir.
So now the guidelines is on following the transient elastography, more on, looking at the transient elastography. So if it is more than less than 8.5, that means advanced fibrosis is not there. More than 8.59, advanced fibrosis, that is F3, F4, more likely. So we'll have to follow with the liver stiffness measurements. That is what is now indicated.
If you look at the methotrexate, quite a few of them are also associated with increased alcohol intake. So we were not able to. Initially, they said 1.5 grams cumulative, we should do it, but found that alcohol was a confounding factor. So then they said 3 grams. So as Dr. Hema said, I think now we ask them to stop alcohol and go with transient elastography based on the kilopascals. Either do it for a year or once in 6 months. It's been recommended. Initially, it's all got confounded because of patients in the West also had a heavy alcohol intake.
Alcohol consumption, okay.
Folate supplementation has to be given, I think, probably for this lady. Folate supplementation, even though it is more as a preventive measure, but even now I think we can give, folate supplementation.
Okay. Because of the earlier that she had taken, no? Okay.
Yes, because
not added that.
Shown to reduce the risk of developing chronic liver injury. I think it's been shown.
Yeah. Okay, we move on to the third case. This was a 10-year-old girl who was referred from the pediatric department with history of fever and jaundice for 4 days. Fever was integral, low-grade and non-polystatic jaundice for the same period of time with no altered sensorium. There were pruritic skin rash all over the body, predominantly over the face and lower limbs with associated pruritus for 2 days. And she had a skin biopsy earlier with the lesion of the forehead. And based on this, she was started on dapsone 100 milligram once a day. And she had taken that for 4 weeks before she presented to us. On examination, she was alert and conscious. She had icterus, there was no hair fringe. Skin showed maculopapular rash over the face, dorsal aspect of upper and lower limbs. Abdomen was soft, liver was enlarged 5 centimeters below the costal margin with a span of 16 centimeters. There was no free fluid, other systems were normal. On lab investigations, essentially
Was there a
she
fever,
had,
ma'am?
sorry?
Did she present with fever?
She had fever for 4 days. When she came, she did have fever, and she also had jaundice at that time. And so the counts was 12,040 with a eosinophil count of 3%. Hemoglobin was 9.4. The liver enzyme showed the bilirubin to be conjugated. AST, ALT was elevated 165 and 236 respectively. Gamma alkaline phosphatase was elevated. Being a child, they thought it could be just a pediatric increase, but gamma GT was also elevated. LDH was 640. INR was 1.7, and ammonia I can't see here, but I think it was around 60. And viral markers, we did all the IgM markers, they were all negative. Ceruloplasmin was normal. We just did an ANA and serum IgG as due to cost prohibition, and therefore it was negative. Ultrasound showed a hepatomegaly, and there was no IHBR dilatation. So, Dr. LBK, you can just take up the discussion whether the dapsone was responsible.
This looks like dapsone-induced hepatotoxicity, because I've not seen much in children because they get admitted in the pediatric ward. But in some of these young adults, I've seen patients getting referred from the dermatology department for having started on them on dapsone. And they predominantly present either within 4 to 6 weeks. Even sometimes they come within 2 weeks of hypersensitive reaction, 2 weeks after dapsone. They come to you with fever, arthralgia, jaundice, as well as very high fever, as well as some maculopapular rashes. And generally, this is, and some of these patients also between, the incidence is somewhere between about, I think Harshad's paper is there. Harshad, are you online?
Harshad, have you joined?
Yeah, I have joined, yes.
Okay,
Harshad,
thanks.
Harshad,
Sorry, I forgot to send him the link,
this,
Sorry about that. Yeah.
Harshad, can you elaborate on this? Because Harshad has got a paper on dapsone-induced hepatotoxicity.
So what's the question, Venkat Krishna?
No, this is a girl who had dapsone.
Yeah.
They came with she took for 4 weeks and came with the prodromal symptoms and jaundice and maculopapular rash. And this to me looked more like a clear-cut dapsone-induced hepatitis.
Yeah, that's correct. And this girl has this phenotype where she fits into the diagnostic criteria for DRESS syndrome. Drug reaction with eosinophilia and systemic symptoms. Now, in DRESS syndrome patients, you might expect them to have eosinophilia, but you find that eosinophilia is only present in about 50 to 60%. And sometimes the eosinophilia is not present on the day of presentation. It may come actually 1 or 2 weeks later. So you probably have to take the eosinophilia or the peak eosinophil count whenever it occurs. So and you'll be also very interesting this dapsone or DRESS syndrome. The most common internal organ involvement is actually the liver. Yeah. So and most patients recover from the skin manifestations, but when they succumb to the disease, which is about 10%, they succumb from the underlying disease or they succumb from the hepatotoxicity.
Yeah. Actually, she came as acute liver injury, so we were a little worried at that stage.
And then you'll also notice a very striking thing about dapsone is that if you accumulate all the cases of dapsone, you find that almost 90% of them are associated with skin reaction. It means they either have DRESS syndrome or Stevens-Johnson syndrome. Only 10% don't have hypersensitivity phenomena. And perhaps you don't have large numbers, but those who don't have hypersensitivity phenomena actually are much worse off than those who have hypersensitivity phenomena, because when you have skin reaction, you present to the hospital much earlier. And most of the time when you have abnormal liver function test, the skin reactions are out of proportion to the liver test abnormalities. It takes some time before the liver test abnormalities present with symptoms. Whereas even with the innocuous hypersensitivity reaction one can present with skin reaction, facial edema, lymphadenopathy, fevers, and all that.
So actually, this patient, we stopped the dapsone, but the dermatologist, they wanted to start on steroid. So what should be
Usually,
the call?
Yeah,
steroids.
I think the classic thing for these patients is to start them with steroids.
Okay.
And again, I always tell, don't get too worried about the fever. The fever is because of the hypersensitivity reaction. Yeah, so just give them steroids. And the other interesting thing about the steroids is the moment you give them steroids, within 24, 48, 72 hours, the fever crashes, the LFT starts improving and everything. But don't stop the steroids.
Okay.
Because if you stop the steroid, then there's a recrudescence of same or DRESS syndrome.
Okay.
So you need to continue the steroids for about 1 or 2 months.
So basically what happens the moment the diagnosis is made, dapsone, fever, maculopapular rash, adenopathy, the DRESS syndrome is made, even the dermatologists make it a very clinical this thing of DRESS, and then starts to, even before the biochemistry comes. Sure. That's what we have always found in our center, where the dermatologists want to use steroids as much as possible. So it is very classical. It can come 4 weeks to 6 weeks after that. It affects about 19 to 39% of patients. As Harshad said, 90% of them come with skin rash. I think that's what probably makes the prognosis slightly better, because the dermatologists don't wait. They start steroids immediately, even before you go and see these patients.
Wait for the patient, sure. And that point was well taken, that measure the eosinophil count a little later, after 2 to 3 weeks. That's a nice point.
Later, even your enzymes or your peak of enzymes may come a little later. They will not come presently at the time your maculopapular.
Okay. Concern was that INR is slightly elevated, so all of us were a little worked up as to how we should do. So we just stopped the dapsone, and I think important is, I think it's a sulfur-related drug, no? So she's likely to have a hypersensitivity to other sulfur drugs. So I think that warning should be informed to the patient. Agree on that, Harshad? Harshad?
Yeah, yes, ma'am.
Sulfur drugs, no?
Yeah, so there is cross reaction between dapsone and other sulfur drugs, and the classic sulfur drugs is Cetran or Bactrim.
Okay, Bactrim. So I think any key message that you'd like to pass on, Dr. NVK, for dapsone?
No, I think dapsone-induced hypertoxicity is a very well described clinical syndrome. Your suspicion is very, very high as soon as the patient on a dapsone comes to you with fever, jaundice, maculopapular.
I think the most important thing was, like in this patient, I think important is to go through the records that the patient has. So what he did again, the physician was again thinking whether it was Wilson's disease and things. When we got into her records, that clue came in that it was dapsone, it was only dapsone.
When I was doing dapsone, we used to see it in patients when dapsone was given for lepra reactions and all.
Lepra reaction, yeah.
And now we see for other dermatological indications where and as I have seen most commonly in younger adults, and the hypersensitivity is quite common in younger adults. But the clinical syndrome of DRESS is so well described that now steroids seem to play a major part in these patients. The mortality could be because anywhere between 5 to 7%, but it's all because of very severe liver injury and underlying liver disease.
Thank you, LVK. We move on to the fourth and the last case before Dr. Harshad gives his talk. This was a patient, a 32-year-old lady, a homemaker. She was diagnosed as SLE in 2008, and she was on Visalon with HCQs. And she was diagnosed as APLA in 2010. And post LSCS, there is a history of, that was when the diagnosis of APLA was made. She had an abdominal pain with ascites and edema, like suggestive of an outflow tract obstruction. And at that time, diagnosis of portal vein thrombosis was also made, and she was started on acetrom, and which she continues till date. And in October 2021, she had a GI bleed, and she had an IgG1, and glue was injected, and she was diagnosed as lupus myocarditis. And the cardiologist wanted to start her on cyclophosphamide, and that's when she received a single dose of cyclophosphamide. And currently she is on Visalon with HCQs, and 1 dose of cyclophosphamide when she had some problem with the liver function test. And what we found was that there was an elevation of AST ALT of 180/400 and an alphas and gamma GT elevation. That was, baseline was normal. So we have a baseline normal AST ALT, And in the month of November 2021, we have elevation of AST and ALT with a rise in gamma GT and alk-phos. And after stop, and then of course, as usual, we just went to the literature and we saw that cyclophosphamide is a possibility because that happened soon after the injection. So we stopped and then we found there was a reduction in the liver function test. Other evaluations she had even earlier. However, she had a past HBV infection of an anti-HBC IgM being negative, but there was anti-HBS and anti-HBC total being positive. And dsDNA was strongly positive. APLA profile, although it was diagnosed then, was negative this time. And ultrasound examination showed extrahepatic portal venous cavernoma, and Doppler study showed a forward flow with collaterals. So the overall diagnosis was chronic portal vein thrombosis with SLE, secondary APLA was a possibility, gastric varices with the lupus myocarditis on cyclophosphamide therapy, and we consider the possibility of a drug-induced liver injury. Dr. Ganesh, you can take up the discussion from here on.
Sachin?
Sachin?
Yes, sir.
Yes, sir. Now, can you tell us what are the ways by which cyclophosphamide can cause a liver injury?
So cyclophosphamide, one is it is a direct, basically, sir, it causes damage to the sinusoidal epithelium, sir, which goes and obstructs the liver sinusoids. So that is, but that is in more severe cases. Otherwise, it is a direct hepatotoxic. By that way, it can cause a idiosyncratic hepatocellular pattern of jaundice, sir.
Okay. So in mild cases, it is only transient
enzyme elevation, yes, sir.
Which may not require probably dose adjustment.
Yes, sir.
But if you use it IV, oral drugs are reasonably safe. If you use it IV in high doses, like in myeloablative disorders, mostly these cases land up with a very severe case of liver injury, which is sinusoidal occlusive syndrome.
Only thing, Ganesh, we were wondering, why they did a liver function test after cyclophosphamide, So there was one report. So I think that's a good suggestion that for new drug is introduced in such patients, I think one message is probably after a week or 10 days, one can do a liver function test just to see so that we don't miss a drug-induced liver injury, especially with drugs such as this. You agree with that?
But it is known to cause transient elevation.
Okay.
I think it has to be monitored.
Monitored.
To cause transient elevation, which does not require any dosage adjustment. But if you use it in high doses, it is required to monitor these patients very, very closely.
Sure.
Because they can land up with acute liver failure and blood compound.
Sure. Now, this patient is also anti-HBC, past infection of HBV. So, and patient is currently on corticosteroid, warfarin, HCQs, just like the first case. So,
yes, Sachin, can you comment on whether the drugs which she is using or the hepatitis B which has been diagnosed in this patient is also contributing to the problem?
So yes, sir, because the patient was on long-term steroids, sir, and being an old case of hepatitis B, we thought of a possibility of hepatitis B reactivation, sir. But given that her anti-HBC IgM was negative, sir, the possibility of reactivation is very less, sir.
And transaminases was also not hugely
not very consistent with reactivation, no?
Yes, sir.
Not very consistent with reactivation.
And the enzyme pattern also, sir, as ma'am said, was more in favor of cyclophosphamide-induced liver injury, sir.
Most of the drugs which she has used are probably not causing much liver issues, except for the cyclophosphamide.
Then autoimmune hepatitis also should be considered because she has this combination, So I think the basic markers were all negative. And the other one was, but Chiari will not come in. I don't think it will come. So this particular observation, can you just comment on this? Because of the high anti-HBS, and she's not aware of vaccination. So what is your comment on this?
Ma'am, it could be because of the past hepatitis B infection, ma'am.
Must be a recent past, no? Must be a recent past because otherwise you usually don't get such a...
The titers are very high, very high titers.
Yeah. LVK? Dr. BT, LVK, any comments on this? A titer of 900.
Yeah, maybe a recent HBS reactivation or... because your total HBC was positive, man.
Anti-HBC total was positive and anti-HBs was positive, indicating a past infection. HBsAg was negative. But we were surprised with the high levels of anti-HBs titer. When you get this type, in a,
when you only
patient,
probably had a recent
okay.
hepatitis B and then
okay. But maybe the IgM would have been positive earlier, much earlier.
Yes, madam. Maybe window period also, we don't know.
Yeah, we do not know. So unlike
there's one more point which you need to keep in mind, Sachin, that cyclophosphamide is metabolized in the liver extensively by the cytochrome P450 pathway. So there are a lot of other drugs these patients may be taking. So you have to keep this in mind, and probably the drugs which these patients are concurrently taking, which have the same pathway, may be required to be monitored and modified if necessary.
So I think this was just a straightforward case. Only thing is that I think, Dr. Ganesh, we have had 4 case discussions now. You can just briefly summarize and tell us, give us some take-home messages on patients. When we should, before Dr. Harshit gives his talk, in our day-to-day practice, can just give us some comments on that.
Yes, I think we have to be aware of the possibility that the patient might have a Dili. They might be referred for just an enzyme elevation. We may not have any history. I think it is our duty to go into the history and check out whether these patients have been taking recently some new medicines, which may not be forthright and coming up. So it is very required to have a high degree of suspicion in patients who have normally get referred to us for abnormal liver enzymes, and then probably we need to advise on them. Some patients come to us with very severe liver disease, but that's not very obvious. But then these patients who come to us as OPD, I think the awareness that Dili might be one of the reasons is very important. And also, we need to know whether these medicines require to be stopped or can be continued under monitoring.
Sure.
Some, like your mild elevations, may not require to be stopped. I think you need to carefully monitor them very frequently.
Especially the Methotrexate case, no?
Level more than 3 times or 4 times need to be stopped. That's also very important.
Yeah, like the Methotrexate was not in an optimal dose, but still we had to stop thinking it may be responsive. Yeah. And I think in all patients, always calculate the Recamp and R factors, especially when you have a suspected. And Dr. Harshad would also concur with me that despite your best history taking, that 20% of patients you still have undisclosed history of a Dili.
Yeah.
Dr. LBK, your comment on that? And Dr. BT, before we progress to...
20% of patients or 30% may not give you the history.
Especially CAM.
And second thing I want to just tell this is that nowadays there's an emphasis on chronic Dili. So we need to know the drugs which can produce chronic Dili, which can cirrhosis, vanishing bile duct syndrome, drug-induced autoimmune hepatitis, and sclerosing cholangitis. So there's now a little bit of focus on chronic Dili nowadays. And this is what I was. So Dili may not just be an acute reversible causes. It can lead on to chronic liver disease, which may not need to be monitored and managed later.
Dr. BT?
Yeah, I think in many of the cases of Dili, the offending drug, it may be very evident, but in some cases the patient won't be telling us properly, and we have to be like almost like a Sherlock Holmes, going through all the records of the patient in the last 6 months. And a couple of times I have been lucky to pick up cases just because I went through the previous records, and patient was not aware what she was taking. She was taking some medicine given by some doctor, that's all. So going through the records of the patient in the previous 6 months, especially any new medicine in the last 3 months, is very, very important. Especially when you have an acute liver injury with no clues to what is the etiology by ordinary investigation.
Thank you. Hema, your final comments before we go to Harshad's talk?
Nothing, ma'am. Everything is discussed. I think all points have been discussed.
Okay. Dr. Ganesh, you can take over.
Yes, ma'am. It gives me great pleasure in welcoming my good friend Dr. Harshad from St. John's, Bangalore. We've been associated for so many years, and he's helped me out in a lot of situations. To give his talk, without much ado, we'll go straight to the Harshad's talk on Dili. Harshad, the stage is yours.
Yeah, one sec. I'm just trying to get my slides. This system is new to me, so let me just see. One second. I'm trying to.
Yeah, it's coming. It's coming. Yeah.
Can you see?
We got it. Yeah.
Yes, yes,
Good.
Arshad,
Yeah,
we can
great.
see your slide.
Yeah. First, thank you very much for inviting me. And I was expecting to get the link, but it took me some time to understand that it didn't come, and then finally I'm here. So thank you very much. So a few points about drug-induced liver injury. We just discussed about Recamp, but I'll tell you things that have just been published a couple of weeks ago. We'll probably have to go to what is known as Recamp, not Recamp, but I'll come to that a little later. So as you have just discussed, it's an underappreciated cause of liver injury, drug-induced liver injury. It manifests with all kinds of manifestations, so it mimics all forms of liver injury. The first important thing is please consider Dili in all your differential diagnosis, because if you don't consider it, then you will not make the diagnosis. And as one of you just mentioned, you need to be a medical Sherlock to go through all the drugs that the patients have been taking for the last few weeks or few months. Now, this is the slide that tells you that Dili has diverse clinical manifestation. You will name any manifestation in liver disease, the liver, drugs can produce the same disease. And there are a pathophysiologic basis for those manifestations. So you find that the diverse manifestations include acute liver injury, acute hepatitis. It could include cholestasis, which could be bland as well as cholestatic hepatitis. Immunoallergic hepatitis, that's the Dapsone syndrome that you saw, that patients have DRESS syndrome and then also have a significant hepatitis. People who take certain drugs like azathioprine and develop liver injury years or months later, known as nodular regenerative hyperplasia. You again discussed a drug, cyclophosphamide, that can produce in large doses sinusoidal obstruction syndrome. So basically, you take a drug, you take a liver manifestation, you'll always find a drug that produces this. So that's why you need to keep the drug-induced liver injury as one of the causes for as a differential diagnosis. Now, this slide I put to just tell you the subtle changes. We all have been used to the definitions that have been put forth by the American Thoracic Society, where any AST, ALT more than 3 times upper limit of normal with symptoms is also considered Dili. But I want to draw your attention to this definition, and this is by the International Working Group, which was published a few years ago. Aital is the first author, published in Clinical Pharmacology and Therapeutics. Now, no matter which journal you publish, people tend to ask whether you have followed this definition. And this definition includes that the AST and the ALT has to be more than or equal to 5 times the upper limit of normal without symptoms. Or you can only have an alkaline phosphatase elevation up to 2 times. This I thought was a very innocuous number, but again, people insist that even an elevation of alkaline phosphatase more than 2 times without AST-ALT elevation, without bilirubin elevation, still fulfills the diagnosis of drug-induced liver injury. And then the third category or third criteria is the AST-ALT more than 3 times, but in addition, they should also have a bilirubin of more than 2 times upper limit of normal. And as I mentioned earlier, and again throughout, we do not have a biomarker or a definitive diagnostic test. It all includes fulfilling this definition, plus more importantly, to exclude all competing causes. And the most important competing causes include obstructive biliary disease, as well as acute viral hepatitis, particularly viral hepatitis E. Now, I had mentioned to you that the first step is always to consider Dili. And again, this slide I just put in is a study where they found that if you very consciously try to look for Dili, then you're more likely to find it. So this study, where they did is there were 2 arms. One is a proactive strategy. The other one is a standard strategy. So what happens in the proactive strategy is there's a central lab, and the central lab just flags AST-ALT elevation more than 3 times the upper limit of normal. So the biochemistry is looking at the labs. He finds that somebody has got an AST-ALT more than 3 times. He calls the hepatologist to take a look. And in this study, out of 1,407 patients, the hepatologist diagnosed Dili in 7 patients. So for an incidence of 0.498%. Now, what happens with the standard strategy? That is only when you have an abnormal liver function test during routine detection or when patients have symptoms, and then you send them to a hepatologist. So you find out of 28,000 odd patients, 12 cases of Dili were diagnosed by the hepatologist. So you find that this incidence is about 0.04%. So this is 0.04%, this is 0.4%. So at least 10 times more Dili is picked up when there is a when the lab or the central lab just flags that the AST ALT elevation can be increased. In other words, trying to show that Dili perhaps is much more common than what is thought to be. Now, these are other studies. As I said, raised liver enzymes always consider Dili. If you have an AST ALT more than 2 to 5 times, you may consider this non-specific. It may be non-specific, but you find that at least in about 2 to 4% of patients who have atrial fibrillation, they may have AST ALT more than 2 to 5 times, and this may be because of the underlying cardiac disease per se. What happens if you have in this study, or if you have an AST ALT more than 10 times or 400? The commonest cause is about ischemic, followed by pancreatobiliary causes. But you find that Dili is about 9% in this study, and acute hepatitis, viral hepatitis in UK is about 4%. Now, what happens if you see a patient with ALT of more than 1,000 or 220 times upper limit of normal, and you find that the commonest cause remains ischemic, followed by acute viral hepatitis, followed by biliary causes. But then you will look at this, drug-induced liver injury actually is the third commonest cause when you have an AST ALT more than 1,000. And if you have only AST, alkaline phosphatase elevation more than 2 times, the commonest causes are always biliary and cholestasis or infiltrative liver disease. But drug-induced liver comes as the third or the fourth commonest cause. So again, if there is jaundice at presentation, again, please consider Dili. Now, this is a study done in UK where they looked at all causes of jaundice at a centralized institute. You find that this was all referred to a secondary care center. They ruled out of certain diseases because of biliary obstruction. And then finally, you had about 881 cases. You find that Dili was the second commonest cause of jaundice in a patient who had jaundice when they referred to another center. The commonest cause, or the other causes include hepatitis A, B, and viral hepatitis, Epstein-Barr virus, and cytomegalovirus. And autoimmune hepatitis was the third commonest cause. Again, when you look at it very carefully, drug-induced liver injury, even in a patient who has got jaundice, in a study in UK, Dili was the second commonest cause. Again, raised AST, please think about Dili. Raised jaundice or presence of jaundice or raised bilirubin, please think about jaundice. Now, as I mentioned, there is no pathognomonic diagnostic test or a biomarker to diagnose Dili. You have to rule out common diseases. And the common diseases, as I just mentioned to you, include viral hepatitis, common bile duct obstruction, and infiltrative lung disease. Now, a few slides on causality assessment. I mentioned to you that Dili is a diagnosis of exclusion. So you had, for example, you have a causality assessment method. So patients need to fulfill at least a minimum causality assessment method criteria to make a diagnosis of Dili. And you have 2 causality assessment. This is a Recamp. The other one is clinical diagnostic scale. All of you are familiar with Recamp. And therefore, there are 7 domains. One is exposure to the medication and onset of Dili. Then you have, of course, what happens to withdrawal after medication. The AST ALT decreases, the bilirubin decreases, so you get a certain point. Exclusion of alternative diagnosis also fetches a certain point. And although re-challenge is not carried out routinely in all patients, inadvertent re-challenge, if there's Dili, then again fetches you certain points. Previous reports of Dili fetches you certain points, including for example, carbamazepine and dapsone and INH and anti-TB drugs. And host risk factors at least was considered as important criteria in causality assessment. And the 2 important risk factors were age more than 55, pregnancy, and also history of alcoholism. Again, recent studies have shown that all these risk factors are really not important. So the one that I'm coming to, the Recamp, has actually deleted this host risk factor. Concomitant medication also fetched a certain points, but concomitant medication, again, in the Recamp that is going to come up, we don't have any points for it. And again, I like this Victoria and Maria diagnostic scale, where they always gave a certain amount of points to extrahepatic manifestation. When I say extrahepatic manifestation, like we just saw a case with Dress syndrome due to dapsone, it's clearly due to a drug. It's clearly due to hypersensitivity phenomena. So you need to give certain points for that. So, but whereas Recamp did not give any points for it. Now, this is the article that I was talking about. It's called a Recamp, which stands for Revised Electronic Causality Assessment Method for the Diagnosis of Drug-Induced Liver Injury. This is published ahead of print in Hepatology just 2 weeks ago. And I think at some point in time, everybody will switch over to this Recamp. So next time we'll be talking about Recamp, not Recamp. Now, how does Recamp differ from Recamp? As I said, a couple of things have been deleted. The latency remains the same. De-challenge means when you stop the drug, what happens to the AST and ALT, that remains the same. 2 domains have been deleted or eliminated. This includes the risk factors have been eliminated and concomitant drugs have been eliminated. You still get points for ruling out competing diagnosis, and the drug risk specific score is actually linked to the liver tox. Your liver tox, when you go, there's an element known as liver tox likelihood score. So if the drug is, let's say for example, carbamazepine, then you get 3 points. If a drug is, let's say, sulfasalazine, you probably get 2 points. That's because there are more number of patients with carbamazepine, phenytoin, sodium, and dapsone and anti-TB drugs that have been reported in literature. So you tend to get more points. And then, of course, you have re-challenge. And as I mentioned to you, nobody really re-challenges unless it's in anti-TB drugs. But then at least in Recamp, you get 1 point if you have Brest syndrome or Stevens-Johnson syndrome. Now, this is the one you will find, for example, this is the Recamp here, and this is the Recamp. And you get a certain number of scores. So you have a diagnostic cutoff of more than 8, then it's, of course, highly likely to be drug-induced liver injury. If it's 4 to 7 in Recamp, it's probable. It's 3 to -3, it's possible. And less than 4, it's unlikely. Now, this site, as I mentioned, http://gihep.com Dili-Recamp is available free on the internet. So next time you always have a drug or you think of drug-induced liver injury, you want to associate the likelihood of a drug producing drug-induced liver injury, please go to this site, type in all the responses, and you get a score on which you can either say there whether it's highly likely or definite or probable or possible. So this is the Recamp score that I just wanted to highlight. So what do you do when you have a patient with Dili? Again, rule out all competing causes. If the patient is asymptomatic, and especially with anti-TB drugs, and you find bilirubin less than 2, AST less than 5, then of course continue the drug. The moment bilirubin goes to more than 2, you know there is a problem. There's a problem in liver function. So you need to be careful and probably stop the drug. Now what happens if a person is symptomatic and has got jaundice? Clearly you need to stop the drug. But how do you treat the patient? Many people, especially if there's cholestasis, give UDCA, although there's no clear evidence it is useful. Again, as I mentioned to you, the case you have just seen about dapsone, if the patient has hypersensitivity phenomena, you of course need to stop the drug, but also try and consider giving steroids. And when you give steroids, please try and consider giving it for at least 4 to 8 weeks. Thank you very much.
Dr. Ganesh? Dr. Ganesh? Thanks, Dr. Harshit, for that wonderful talk. Dr. LVK and Dr. VT, they are not discussing CAM here, but very nice and brief presentation. Thank you so much.
Yes, Harshad.
Yeah.
Hi. Very nice talk. And two or three things which are very important is that when a patient comes with the jaundice, Dili has to be there because it is one among the 3rd important causes. And also when transaminase elevation is there, that has to be important. Those were important points. I think giving steroid for 4 to 8 weeks is another important point. And Recamp is another new thing which I have learned today. Thank you, Dr. Harshad. So Ganesh is there.
Oh, thank you, Arshad, for that wonderful talk.
Thank you, Ganesh.
Very informative. Thank you. Thank you so much.
Thank you, sir.
VT?
Nice talk, Harshad. And the thing is, in this Dili, just a question right out of thing. You did your analysis of this scan. You took all the medicines and sent it for analysis.
Yeah.
What was your major finding in this scan?
We had ingredients only from few patients because you realize people filled in the data and sent it. Many times it was just they said CAM and powders and it was unlabeled.
Yeah.
Unlabeled. So but whatever few we had, and I think we had 5 patients whom we actually sent the ingredients to USA. The Dili group actually did the analysis for us. And some of the ingredients that were brought out were very common ones that have now have been linked to Dili. For example, ashwagandha. There is a Einar Bjornsson study published in Liver International of 5 cases of ashwagandha. Now you find that now there's a lot of talk on Giloy. It evokes so
Plant
much of
steroids,
interest. Yeah, and Syriac Philip, Eddie Philip, has just published his series in Hepatology International 4 or 5 days ago on his series about 44 patients. Abha Nagaraj published on her 6 patients, and then there's letter to the editor after Agava's publication for 9 patients. It's astonishing how these medicines or these drugs that you think are more common have in some way impact the liver. And particularly with regard to Giloy, it seems to be an immunostimulant. That's almost 2/3 of patients develop some sort of drug-induced autoimmune like hepatitis. Can you believe it that almost 2/3 of patients have raised ANA / SMA or smooth muscle antibodies?
Yeah, smooth muscle antibodies.
More than
What is it given for? What is it given for?
Madam, actually, it was given as an immune booster for COVID.
Okay, COVID.
COVID, yeah. So, but we have to be very careful because these are alternative medicines. A lot of backlash is there. So, but from whatever published sees that they have done extremely good job, and the Giloy that was published has also been accompanied by an editorial by Einar Bjornsson, Naga Chalasani, and Victor Navarro. So they also have looked at the data and find that it is very convincing. So it's not just publication for publication's sake, but this has been externally validated as such. So I think my plea to all of you is that should you see a case with complementary medicine, please work them as much as possible. And I think with Recamp, you don't have to do Epstein-Barr virus, herpes simplex virus, and cytomegalovirus. One can always argue and say that was not done and this was not done. But with Recamp, it is extra doing whether you do Epstein-Barr, herpes simplex, or CMV. Doesn't fetch you extra points unless, of course, you clinically suspect.
I just want to add just one point. LVK, I have seen 2 cases where the patients have taken green tea. We have thoroughly investigated and did not find anything but green tea. And finally, when they stopped the green tea, everything settled. Just green tea.
Varghese, I think you should please assemble those data, accumulate the data, and at least in an abstract form present it somewhere, because people always ask me, and in fact Jay Hofnagel once sent a message to me saying, we see so much of green tea, and green tea is associated with some HLA phenotype. How is that India drinks so much of tea and yet you do not see any green tea induced? I'm glad that you at least have started seeing it. Maybe you can build up on the data and ask your like-minded friends to contribute.
We have collected 17 CAM and sent it to our PSG College of Pharmacy, where there's a pharmacovigilance, and one particular faculty does on all this CAM. So we sought a lot of phytosteroids, as you said. Some of them had cobalt. And we also looked at some of them had some plant steroids. And as you said, 2 patients had ashwagandha. One of the ladies presented with a Dili, and when we did a liver biopsy, it was Dili-induced sarcoid-like picture. She was taking it for her joint pains for nearly 1 year. And the Dili which contained cobalt, that patient came with profound hypothyroidism along with Dili. So we were able to do for about 17 patients in our institution. If they are able to procure that medicine.
Dr. Hema, would you like to comment? Dr. Hema?
Nothing specific, ma'am. Nothing specific, ma'am. Sorry.
Okay. Thank you, Harshad, for the wonderful talk. And I'm extremely sorry. The link went to all the panelists except you. Thank God you asked me for it.
I got
sorry about that. Okay, Dr. Swati, please conclude. Thank you so much.
Yes. Okay, we now come to the end of the session. I would like to extend my thanks to Professor Harshad for taking time out of his valuable schedule. I would also like to thank all faculties involved in the case discussions. I think we had a very, very clear and detailed discussion, and I think many of the doubts would have been cleared. So we will now come to the end of the session, and we will meet again next month with another interesting topic. Thank you.
Thank you all. Thank you very much. Thank you, Ganesh, VT, LK.
Bye, Harshad.
And Harshad. He's left. Thank you all. Thank you.